Good afternoon. Thank you for joining us for today's WST Grand Rounds. My name is Sara Edwards. I am the Division Chief of Acute Care Surgery in Riverside University Health System in Riverside, California, and Associate Clinical Professor at UC Riverside. I will be moderating today. We are joined by Dr. Stephanie Lueckel, who is the Associate Surgeon in Chief and Section Chief of Trauma in the Division of Acute Care Surgery and Surgical Critical Care at Rhode Island Hospital. She is the Associate Clinical Professor at Warren Alpert Medical School at Brown University. Dr. Lueckel has been instrumental in the support of transfusion-free care at her university, advising other physicians and surgeons in blood conservation strategies. And in her research, she has written extensively about geriatric trauma, about prognostication in the ICU. Dr. Lueckel has also supported training, surgical training internationally with partnerships in Malawi, Africa. Before we proceed with our presentation today, please note that the WST is no longer offering CME for live grand rounds. Should CME be available for the archive version of this Grand Rounds, those who watch today's webinar will receive an email once the archive version is available on the WST website to prompt you to log in and claim CME. And now, if you could please join me in welcoming Dr. Stephanie Lueckel in her presentation, Are You There, God? It's Me, Palliative.
Thanks, Dr. Edwards. All different iterations of this title, and I went with, Are You There, God? It's Me, Palliative. And as I was writing the talk, I realized that I would probably have to explain that a little bit to the younger population, perhaps. And it's a reference to a Judy Blume book that I know I read, I think, in like the 5th grade. Are You There, God? It's Me, Margaret. And I'm just going to read you this quote because I giggled when I was writing the talk about this. Are you there, God? It's me, Margaret. We're moving today. I'm so scared, God. I've never lived anywhere but here. Suppose I hate my new school. Suppose everybody there hates me. Please help me, God. Don't let New Jersey be too horrible. Thank you. And the don't let New Jersey be too terrible just struck a chord with me because I grew up in Philadelphia and have been in the Northeast my whole life, and New Jersey does have somewhat of a reputation over here on this side of the country. But this book really talks about a young girl who has a Jewish father and a Christian mother, and how she navigates the world with really no affiliation. And I thought perhaps it would a good intro. On to my disclosures. I was baptized Greek Orthodox. That's me in the May procession at Gwinnett Mercy Academy. I went to Catholic school. Behind me, so this is me. I don't know if you can see my arrow. That's me with the buck teeth. And behind me, that's Summer Pio, who is now a radiologist in Philadelphia. My best friend is Jewish. This is her here. Ann Barron at our senior prom. But with all of that, I find I identify more as spiritual than religious, and do carry that through my life, through my practice. So this presentation, I apologize for my voice. I'm in the midst of a cold. But this presentation is going to explore the role of religion mostly and spirituality in palliative care. And we'll get into sort of the subtle differences between the two, religion and spirituality. Excuse me. And the key concepts are really that, palliative care is a holistic approach. So it hopefully looks at all aspects of the patient, of which I feel strongly that religion and spirituality are a part of, because they can influence the decisions and the coping that a patient goes through at the end of their lives. So in all of my palliative care talks, I put this dog with the cloak over it because it popped up when I was Googling images for palliative, and I use it all the time now. And it's because the word palliate comes from palliar, which means to cloak, which means to wrap something and make that comfortable. And so here we are. We have this, I don't know what kind of dog it is, maybe a black lab, cloaked and is comfortable. So palliative care in medicine, what is it? It's specialized medical care that focuses on providing relief from symptoms and improving the quality of life for patients with serious illness, terminal illness. And I think these goals really sum it up. As we know, it's pain and symptom management. That's definitely part of it, but palliative care also incorporates helping to support the emotional and psychological being of the patients, their family, and helping with difficult decisions or helping the patient to make some difficult decisions. So this is what I was alluding to, the subtle difference between religion and spirituality. And I'll read this quote from Christina Polchowski, who's a board certified internal medicine and palliative care doc, and she's the founder and director of the Institute for Spirituality and Health at George Washington University. And she says, spirituality is a dynamic and intrinsic aspect of humanity through which persons seek ultimate meaning, purpose, and transcendence, and experience relationship to self, family, others, community, society, nature, and the significant or sacred. Religious communities' beliefs and practices facilitate spirituality for many people. And she goes on to explain in that quote that spirituality is probably the larger of the two umbrellas of which religion fits into, but spirituality can really be found for people in nature, in in their family, in their vocation, and all can be incorporated into holistic care. But I do, in this talk, focus more on religion specifically. So how can religion be incorporated, or what role does it play? I think for the most part, what we'll see is that it helps people to cope with illness, perhaps help explain the illness, and understand the suffering that goes along with it. And the faith can help with that. The faith can help with the meaning of the illness or the suffering from the illness. And at times it can offer hope, acceptance, when patients are dealing with the terminal, with the finality of their lives in such certain situations. So I do think it offers one area of support. A recent survey in the early 2000s, which to me is still recent, actually looked at religious characteristics of U.S. physicians. I pulled out some of the statistics on surgeons because I felt that was probably going to be my audience, but this was a national survey. And surgeons are generally more religious than the general population, which I found incredibly interesting. Furthermore, 68% said that their beliefs are part of their practice, are incorporated into their practice. Over half believe in God and also identify as religious. 44% of us pray daily. That might be in the operating room, who knows? And a little more than that attend services weekly. This next fact I also found to me counterintuitive, but a survey found that Christian, Mormon, and Buddhist doctors were most likely to say their religious beliefs influenced their practice, while Jewish and Hindu physicians were least likely. I couldn't immediately come up with a reason for that, but excuse me, as we move on, this may begin to make a little bit more sense. And finally, physicians in general are more likely to believe in God than other educated people in science, which wasn't well defined in the article, but I think we probably have a general sense of what that means. And again, found that to be incredibly interesting. This survey was done at the University of Chicago, I believe. It's worth a read. It's pretty interesting. So I'm going to go through a couple articles that focus on various religious and ethnic groups and how those influence their religious beliefs, and thus how that impacts their views of medicine. Of course, this is not all inclusive. This is truly meant for education, and does, I don't think, represent all of the aspects of the various religions. So this was an article looking at end-of-life attitudes between Latino and Cambodian patients. Excuse me. And you'll see here that the majority of both groups believed that dying was inevitable, and that having something like an advance directive was moot, because when it was time to die, it was time to die. And this probably explains why only 15% of these patients ever had any kind of discussion ahead of time with regards to end of life with their physicians. Both groups, the Cambodian and Latino population in this study, expressed that if the quality of life was poor, that there was no point in continuing with medical care. But when religion specifically was mixed into the discussion, the Latino group felt that removing life support was the same as killing a patient, which was really quite dramatic, I thought. And while the Cambodian group really delegated decisions to the spouse or to the children, the Latino group felt that the extended family should be included, and there should be more of a consensus with regards to decision making. And back to this removal of life support, the Cambodian group didn't think that the two were related, in the sense that the end of life decision making was not relative to their religious beliefs. This was an article looking at, this was a little bit of a difficult read, but I also again found it interesting. And Van Lorven looked at Dutch patients and the images of God. And here you can see the three categories, which was a non-personal image, a personal image, or an unknowable image. Sort of this being that had no face at all. And I thought that was interesting with regards to, you'll see in the columns, with regards to the coping mechanisms. So those patients who had a personal image, perhaps they could draw what they thought God looked like. They tended to use religion more as a coping mechanism, whereas those who had no idea didn't use religion at all as a coping mechanism. People who had no personal image but had some idea of what that being meant to them, in this article, this sort of image that they could connect to but not in a personal form, were more subject to denial and sought advice from others, and they were less likely to rely on a sense of humor, which I found really, really interesting. And I'm not entirely sure how to relate the humor here, but it was a finding nonetheless in the paper. This article by Kinsberner looked at medical ethics and the end-of-life care in the Jewish population. And you can see there that overwhelmingly this religion provided opportunities for patients to choose comfort over medical care. It was understood that comfort could be a priority and that pain and suffering can be minimized, understanding that this may shorten the life of the patient. This paper out of Saudi Arabia looked at the legal issues in end-of-life care. So in Saudi Arabia, the constitution and the legal system is based on Islamic law. Islamic law itself has its own interpretations, but this referred to a very specific type of Islamic law, and that life was sacred but finite. Again, you see here that things like euthanasia and assisted suicide are not permitted. But what was different in this paper, or what was striking to me in this paper, was that families were not consulted with regards to decision making. this isn't meant to say that they were not told what was happening necessarily, but they were not consulted with regards to what to do next. Excuse me. Such as do not resuscitate orders. Do not resuscitate orders were completed, were finalized with the permission or the determination by 3 physicians. So 3 physicians taking care of that patient could make the determination whether or not that patient would be DNR, and thus with that more paternalistic approach, living wills and advance directives were not recognized. And we can get into a little bit more of a discussion with regards to this, but again, these are summaries of the papers that I used for this presentation. This next article by Bradley looks a little bit more at end-of-life care as it pertains to Roman Catholics. Again, I learned a lot reading this paper, but there's a distinction between ordinary and extraordinary treatment of care. And their definition may be different than perhaps what you hold to be true. Hydration and nutrition in a persistent vegetative state is considered ordinary care and therefore must be administered. Extraordinary care, again, according to Bradley, extraordinary care does not offer reasonable hope or benefit. So I thought that was interesting that hope is included. And it's considered extraordinary if there's an excessive burdensome to the patient or the community. Again, I thought very interesting and not what I had initially thought. However, there's a lot of gray area. There's a wide berth for accepting or refusing treatments in Catholicism, but again, euthanasia is prohibited. I think this was the last religion covered that I could find. That doesn't mean there aren't more out there, but this was an article looking at pain and suffering as viewed by the Hindu religion. And pain and suffering, according to the Hindu religion, is part of karma, which is to say that if an individual has pain or is suffering, that's where they are supposed to be, and it is a consequence of karma. However, it is meant to be temporary, and it doesn't necessarily need to be viewed as negative, but it is to be accepted as a natural consequence. The goal in Hindu religion is to detach from the world with its pain and suffering in order to concentrate on God. So it's an acceptance and then a detachment. And that is the main goal for Hindu religion. And so that pain and suffering is more accepted, I would say, as compared to some of the other religions we've gone through. Excuse me. So shifting gears a little bit with regards to interacting with patients, understanding some of the basic beliefs and perceptions of end-of-life care in some of the religions that we went through. This paper out of Vanderbilt looks at types of miracles, if you will. This paper was, I thought, phenomenal in helping guide a conversation. I'm sure that you've all been there when a patient says, well, I leave it up to God, or there'll be a miracle. And sometimes it can give you pause and struggle with a response. And so I thought that this categorization of approaches in response to patients, was really helpful. So like I said, this was out of Vanderbilt, Dr. Chenal, and she talks about these categories of innocuous miracles, shaken, integrated, and strategic. And we'll go through them. Some of them, as by their names, are probably a little easier to navigate in a conversation, and others are not. And I'll sort of pull from the paper some little vignettes that they use to sort of help explain it a little bit more. But as the name implies, innocuous is probably one of the easier conversations to have. And all of these conversations for the purposes of the vignettes starts with the healthcare provider saying, what is the miracle that you're hoping for? So you'll see this over and over. And a response with regards to an innocuous miracle would be, I don't know. You never know what'll happen. Maybe there'll be a new drug, procedure. I know it's unlikely. My time is short, but maybe. And so an innocuous miracle is more hope, with an understanding that that's probably unlikely. And there's no real emphasis on sort of divine intervention. And responses, as with many, is, of course, you're going to always affirm the hope for the patient. I mean, of course, everyone hopes, so do the healthcare providers. We can all hope. And then make some plans based on, the patient's level of acceptance. And so a couple opportunities, I hope so too. We hope so too. The team taking care of you also hopes. And then the patient has some understanding. Yes, but I know the facts. And again, this acceptance or this affirmation of the patient's concerns, I wonder if it would be okay if we talk about what happens if there's no miracle. So you accept that that's what the patient is hoping for, and you also are able to move on to discuss further where this may go if there is no miracle, but it doesn't, of course, say that there won't be. The next category is shaken miracle. So a shaken miracle is recognizing again that there's a possibility of some type of recovery, but probably won't happen. But then there's an associated anger with that. Sort of, why is this happening? Why haven't I had my miracle? I do everything right. I deserve this. What's God doing? Kind of thing. And so, again, what's the miracle that you're hoping for? And the patient may respond, I've been hoping for a miracle since I got the diagnosis. Why is God letting this happen to me? And that's sort of where you start to see, that anger, that sadness, that confusion, that conflict of, I've done everything right. Why is this happening to me? So it's sort of that next step above innocuous. Again, you want to affirm the feelings, the expression of the patient. And this may be where you want to engage a chaplain, somebody from pastoral care, depending upon the religion. And again, you affirm it's unfair, you've done everything right, and still things are going wrong. And the patient may express that they're scared and they're angry. And you ask, what are you angry at? Why are you scared? I'm angry at God. And then you can probe a little bit more. So faith is a part of your life. Faith is helping you make decisions and make some understanding of what's happening to you. And then you can give the patient the opportunity to talk about how they feel that their God has let them down. Tell me about that. And again, you affirming and moving on with one of those statements. Well, if the miracle doesn't happen, can we talk about what's going to happen otherwise? This is, for me, this to me is the most difficult, and she terms this the integrated miracle. What's the miracle? What's the miracle you're hoping for? We are Christians and we believe in a higher authority than the doctors. If he says I'll walk, then I'll walk. If he says I'll live, then I'll live. Are you talking about God? That's right. Jesus told the paralytic to rise. It could happen for me too. Our church prays for me. The elders have laid hands on me. The Lord's watching, so I'll never give up. So this for me personally is always very difficult. And these miracles are this true hope for divine intervention, if you will. There's usually a strong connection, not just to their God, but to their religious group, their community, their church, what have you, and lots of people involved, and these can be difficult to respond to. As you know, we have no control other than the medicine. And this again is probably where you're going to not only involve some of the religious leaders, but perhaps even some people from the community that definitely have the same understanding as your patient or the patient's family. And again, you want to have an understanding of what they're saying, an acknowledgement of what they're saying, and then try to incorporate their view with the medicine. And a great response, again, in this paper many times over, it says, the healthcare provider says, it sounds like your faith guides your decisions. And that is sort of a nice segue to incorporate not only the medical care, but the care of, but the religious care, if you will, or the support for the religion. And I wanted to read this directly from the paper for you. Ooh, sorry. So the healthcare provider says, it sounds like your faith guides your decisions. And the patient responds, exactly. I know that sounds funny, but I'm happy to do whatever the doctors tell me so that I can live to see my miracle. And the healthcare provider responds, all your doctors hope for that too. And I think that that's key. I think it's key to say, to bond with the patient and say, we hope too. We want you to get better too. And make sure that the patient and the family understands that. We respect your wishes and your hope, but we would feel guilty if we do things to you that we feel won't work. And to me, this is where conversations for me have become difficult, because you get to that point where, as a physician, you don't think that the treatments will help, but the patient is asking you to do more and more, or the family usually is asking you to do more and more. The patient responds, well, I'd never ask you to do something you think is wrong. I just want you to do everything possible to keep me going. And I think that that's a little wedge in the door to help the conversation go and perhaps move forward from a medical perspective. But these are really difficult. And I think, again, incorporating from the patient's view that they, quote unquote, want to do everything within their means so that they are, quote, around long enough for God to intervene. And I think that this is really difficult, especially when we're talking about, quote, there's nothing left to really do for the patient. You know, you've sort of used all the tricks up your sleeves and the patient continues to decline. And where do you go from there? And I think really spinning it like they do at the end here, that, you know, we would feel guilty if we were to do things that we don't think will work. And I think that helps put the doctor in parallel to the patient's views. And I'm hoping we have time for discussion, because I think this is really interesting. I would love to hear how y'all handle this. And this, I think we've also come across in the strategic miracle. And these are less religious based, but perhaps using religion as a tool or as an avenue to express anger. So the strategic miracle actually has minimal commitment to the religious worldview or community, and it's an unwillingness to discuss further. It's often adversarial, and an attempt to hold on to rights and to sort of protect, but in a more defensive way. So we start again. What's the miracle that you're hoping for? You're not God. You can't tell us what we can and cannot do or what's going to happen. We believe in God's power to do miracles. The doctors have come and told us what they can't do. And I know what you're here for, right? We've all been in that situation. I know what you want. You're going to tell me to give up, right? What's that? To tell us to give up. I know the hospital doesn't want to deal with us, but we won't accept that. God can do what you can't, and we're holding on for our miracle. I mean, I feel like almost the exact conversation has happened to me many times. Again, it sounds like your faith guides your decisions. And I just love that, because it's really a way to stay aligned with the patient, but again, to move it forward, because those statements are pretty definitive, right? Frankly, it's none of your business. all you need to know is that you can't walk all over us because we have rights, and you can't tell me a miracle won't happen. So just do your job. And again, in this little vignette, but, in reading more about this strategic miracle, it's often not about the religion, but rather there's a mistrust or a misunderstanding between the healthcare team and the patient or family. So you don't trust the doctors to do the right thing? We have our reasons. And there you have your opening, right? You have your wedge in the door. Well, tell me your reasons. And then hopefully that is an opportunity to move forward. Again, we're affirming the feelings of a potential miracle, of this helplessness, of this anger, and then try to sort of break it out and really tease out where the anger is coming from. And often, if you can whittle it down, it's usually some basic misunderstanding or some basic miscommunication that has gone on between the healthcare team and the patients and or their families. And if that can be sorted out, then often you can move forward. So how do we integrate religion into palliative care? I mean, I think we've sort of created a groundswell here for how it is important, and certainly how it pertains to a holistic approach, right? It's definitely coming at a patient at a completely different angle from science or medicine. So including religious beliefs in comprehensive assessments to address the holistic needs of the patient, and we'll get into some assessments a little bit later. Excuse me. Chaplains, of course, and any religious leaders can offer support in parallel with the teams, the healthcare teams, and, as much as possible, honoring the religious practices that are important to the patients, in terms of dietary, prayer, visualization, timing, and then, of course, providing any resources as it relates to their personal religion or their personal beliefs. So the spiritual assessments, there are a few, and they sort of build on each other. As best I could tell in reading this, because this was very much new to me, is the PC7, and then the spiritual assessment, the spiritual aim, and then the next to build is the outcome-oriented chaplaincy. And this paper was written by a chaplain and a palliative care doc, and they looked at how to implement these smoothly. They suggest that all healthcare providers should be able to use these tools to assess the spiritual or religious needs of a patient. In reading all three of these particular assessments, they're a bit lengthy. I do think they would require some training in mental health or behavioral health to truly grasp the needs of the patient as it pertains to spirituality. But we'll go through it nonetheless. But I do think it would be difficult for all of us to incorporate this with all of our patients. So the PC7, again, like I said, assesses the concerns in palliative care patients. It looks at their need for meaning, integrity, legacy, what they're going to leave behind, what's the purpose of this, concerns about or fear behind death and dying, decision making, and then, of course, that internal conflict of, why is this happening to me? I'm a good person. Excuse me. And the next assessment, this spiritual aim, really uses the PC7 and puts numbers to the assessment. And then, of course, the addition in this assessment was to add, quote, a zero. A zero indicates that there's no explicit evidence of religious or spiritual concerns, so there's no overt evidence, but that the chaplain or the healthcare provider or whoever's doing the assessment feels like there's a little more to do. And it looks at, so I'm really sorry, guys. It looks at, I think I have it listed. Oh, did I not list it? There are four components. Oh, here they are. Yep. The four components are spiritual, emotional, relational, and biomedical. And so that's where the spiritual aim is scoring. And then again, this 0 star or this 0 score is when they're not checking the boxes as built into the assessment, but that the provider thinks that there's something more to do. And again, out of that, the outcome-oriented chaplaincy was born. And this is a framework for perceiving the 4 domains we talked about: the relational, the emotional, the spiritual, and the biomedical. And this is really almost like an entire program, a lengthy assessment of these needs and how they can all be incorporated. And this was the one that, of course, now they have turned to. This is the most recent, I think 2020, that they're using to assess the needs. And I think that this is where you would really need someone from your hospital specialized in this. I think it would be a tough ask to have the surgeons do this on all of their patients. So what are the challenges? I mean, I think for the most part, when we're talking to someone and there's a disconnect between the medical and the spiritual, that's probably one of the most difficult conversations to have. And I'm hoping with this presentation that, you know, you can sort of align the conversation a little bit more and have an understanding so that those conversations can move forward and are not just, you're the doctor, you don't understand, God's going to help me, and then the conversation stops. So, you know, of course, there's diverse beliefs. They hold on to even non-religious beliefs, religious beliefs, non-religious beliefs. And that's where you need to sort of tailor your approach. Of course, we have to be culturally sensitive, and religion rolls into culture, culture rolls into religion, and all of those practices, and we have to be sensitive to them. Religions, as certainly as some of the ones we discussed, have pretty strong feelings on euthanasia, advanced directives. We didn't talk about it, but organ donation, blood transfusions, all of that can be and often is based in a religious or cultural belief. And then, you know, it's distressing to patients, and they again have sometimes these existential questions, right? These questions that could be answered in a million different ways about why this is happening, should this happen, how can I support myself, what's going to happen when I'm gone, things like this. And it can all be quite gray and quite confusing. On the positive side, what are the benefits? Well, it can really help pull a patient out of their heads, so to speak. It can bring them into the present. It can eliminate some of that isolation, some of that fear, certainly as it's not only discussed, but felt to be supported. Religion offers a sense of peace for many people. Ritual offers a sense of peace for people. I mean, think about some of the things that you do every day, all day, in or out of the operating room that sort of give you some calm when you've done it or when you know you've done it. It can improve a patient's understanding of their purpose in life and accept the disease or the illness that they've been handed. Religion can provide a framework to cope with the pain and the loss, acceptance again. And there's papers that show that people actually clinically do better when they have strong religious beliefs and stick to those beliefs. And then faith can, of course, bring families together during times of difficult decision making. So some of the key takeaways, I am so sorry about my voice. Religion and spirituality are vital components of palliative care. I think that we all sort of know that, but actually how to discuss it and approaches and understanding are probably a little less known. But respecting and integrating those beliefs can build more trust between the healthcare team and help with the psychological and the emotional outcomes, in addition to hopefully making patients overall more comfortable. So I do think that this is something, certainly in the palliative world, or in the palliative slash surgical world, that needs to be incorporated, needs to be discussed, needs to be asked, quite frankly, ask the question. And I think the more that we do that, some of these holistic approaches will coincide, and the team and the patients will be able to move forward. So final thoughts, religion can play an essential role. And again, remember, religion is under that umbrella of spirituality. Spirituality can help you cope, can help you accept, can help you endure. Religion is a more specific form of spirituality. And so that's in general, but religion is what we tried to focus on today, in the different religions. And so they do play an essential role in helping patients as they traverse palliative care. And I do think that we all need to be more sensitive. We need to be more sensitive in general, I would argue. We're all understaffed and underpaid and trying to rush through the day sometimes. And we all do need to stop and give pause and sometimes ask the patient what those needs are. It may not be a medicine, it may not be a surgery, it may be just be a discussion. Why is this happening to me? So I challenge you all to maybe take that extra time. These are my references. I want to bring your attention to this paper, number 8. I really found this incredibly interesting and helpful, with a few tools, as hopefully I demonstrated here, as a way to have those conversations with patients and keep having the conversation so that they don't just stop. Number 9, outcome-oriented chaplaincy. That's what I was talking about as one of those assessments toward the end. This is not a paper, this is an entire book. So like I was saying, I think it's a tough ask to have us do that. But it is nice to know that there is an assessment in place, and there are people that are trained, board certified chaplains, who can perform these assessments. And lastly, number 10, again, it's in relation to cancer, as so many of these papers are. But again, it dove into some of the cultures specifically, and how to navigate them. So those were my most favorite references that I used in this paper. The other ones are more specific to certain religions, also helpful. But if you were going to read any, I would say those number 8 and number 10 are probably the best. Thank you so much for logging in and listening to me ramble about this topic. I think it's a difficult topic, but important nonetheless, and actually a useful tool in our armamentarium when we're caring for patients, especially at the end of life. And I would love to see some discussion or answer any questions that you may or may not have.
Yes, I want to thank you, Dr. Lueckel, for presenting this topic. I think I agree with you. It's incredibly important. It's really a fundamental part of our patients that we don't often explore, but maybe actually one of the biggest players in the room as we're engaging in conversations about care and care pathways. So I really appreciate you highlighting this topic for discussion. I want to encourage those who are here today and participating in the webinar to join us in a further conversation regarding religion and spirituality in palliative care by typing into the chat any questions or comments that you have. We look forward to seeing those. And in the meantime, I have a number of questions myself and comments that I hope to share. The first, well, I've quite a few, but the first I wanted to ask you. You described the you went through a series of different perspectives in faith and spirituality, and in particular, you did highlight about Saudi Arabia and the sort of what it was a very sort of portrayed as a very paternal approach to medicine, with the physicians making the final declarations. So I wanted to speak a little bit to where you see the intersection between culture and faith, and how those may interplay in this dialogue.
Yeah, this was a really interesting paper to me, and it actually spawned some conversations with some of my partners. One of which he doesn't practice Islam, but he was very knowledgeable, and his mom does, and he was saying that it takes it. There's a lot of faith and trust in the medical community, which I suppose is nice. But the patients are very much removed, and the decisions are very finite, which is a little bit different than what we're used to, but I think something that needs to be respected. Um, and I think approached differently. So, for example, if that is the faith of the family that you're going to have a conversation with, know going in that you will probably need to be perhaps more definitive with your statements, and less, well, we could try this or we could try that. And what do you want? And what does this person think? Because that's not what is expected. What's expected as a physician or two to come in and say, we've done everything that we can do. We don't think that there's any more that we can do. This is the diagnosis. This is what we've done, etc. And then there will probably be an understanding and an acceptance, which is a little bit different. There's often a back and forth with regards to, further treatment, trachs, pegs, things like that. And I think understanding where they're coming from is probably going to change your approach, but probably not the decision. What I found interesting that was not highlighted in the article, but came up in conversations as I was talking about this, was that at times, patients are not made aware of their diagnoses at end of life. And that I think knowing that is important, because that comes from the family. The family does not want the patient to know, because they think that that contributes to suffering. So I think understanding that, knowing that, also will change your approach. So perhaps you go to the family with your news and ask if you think that the patient would want to know, and how to navigate that. And I don't know the right or wrong answer there. I mean, I always feel, of course, this is my own personal bias, that the patient should know, but understanding that religion tries to protect the patient in that way, certainly is something you should have in your back pocket when talking to them.
Along those lines, I do think some of the palliative care training that we have around communication, like spikes, for example, if you were to pick a model, talks about that introductory, where you the invitation. So asking people how much they want to know about their diagnosis, or whether or not they want to know at all. And sometimes it's a really subtle step that you kind of trickle over as you move into conversation, but it sounds like perhaps that's a place where we might pause a little bit longer, whether that's for a specific population or integrated in all of our conversation, right? That maybe we could just take a little moment to make sure that we're giving people the information they want, and that certainly if they want to redirect it to somebody else, that may be a really valuable step.
Yeah, I agree with you. I that's something I'll probably change after having read all of this, because I don't think I do that well enough. I will usually divulge as much information as possible to patients, and probably should pause, like you're saying.
I um I uh I also so I grew up in sort of a very, it's probably softly Judeo-Christian home. I have family actually in Israel, but I am personally not someone who was devout in practice. But I also trained in New York where there were, was a very large Hasidic population. So when you brought the slide up um, about the Jewish faith and commented yourself that where some of this was sort of unexpected when you were reading um, through that slide. I wonder what you might share with us about thoughts about how to approach things with the diversity that you can see even within a religion, to communicate with patients. So, the framework, but how does it play out patient to patient, and maybe some recommendations around that?
I think I think pausing when you said that, I think that's the greatest thing you can probably do in these meetings is just like take that extra pause to make sure that everyone feels included, because I've definitely approached families understanding the patient's faith, if you will, but not understanding necessarily, the husband or the children, or like you said, you grew up this way, you've got family here, but maybe that's not what you personally practice. And I've definitely gone into family meetings assuming that everyone is going to be in the same page with regards to the spectrum in their own religion. And so sometimes saying, the facts of the medicine as I see it, and then sort of asking and emphasizing what the patient would want based on the patient's beliefs, and trying to really create that, I don't know, that perspective in who it is that I'm talking to, right? Have them sort of lock into not their beliefs, but the patient's beliefs. And I think sometimes that's really hard for families. Um, if they say, I want this, I want that, based on this, based on that, and then you sort of redirect and say, well, is that what patient X would want? So I think that's sort of the framework, is you can incorporate your understanding of their religion, the patient's religion, however you want, but making sure that you emphasize that it's the patient that the decision needs to be made about. Does that make sense?
Yeah.
Yeah.
Yeah, and I think that's really challenging, right? Because we all come into the room with different baggage, and the expectations of the family, I think, don't always align right with the wishes of the patient. Some of my most challenging cases have been where the patient themselves did not share the faith of the family, or vice versa, right? They were very devout and the family was not, and so they were not aligned for a very long period of time, and then the decision making around goals of care got caught up in that sort of divisive environment that was
Mm-hmm.
already pre-existing in the family.
Mm-hmm.
I
Go ahead.
That's okay.
I was gonna ask you a question, just since we're having a nice chat. I had a family once, and I didn't address this in the talk specifically. It's a sort of a specific scenario, but brain death. So the heart's still beating, right? And that's sometimes a difficult concept for families. And it would be that strategic miracle. So I went in to tell the family that the patient was brain dead and thus dead, and the time of death, and what would happen next. And I had a really scary interaction where the son of the patient looked at me and said, "We don't believe you. We believe God." And I I paused, and I didn't know what to say, because here I have a dead patient, and I have a family saying, no, he's not dead. His
Yeah.
heart's beating. God still has him alive. And I was like, whoa, I don't know where to
Yeah.
go with this. I do not know where to go with this. It was really challenging. And I wonder if you've ever had something like that.
Yeah. As a fellow, I actually cared for, I've actually had this happen a couple of times. And I think culturally and spiritually, there are some faiths and cultures that believe that death occurs when the heart stops, and the concept of death by brain criteria is not a concept that exists in that population. And so how we reconcile, modern science and legal expectation with, you know, a several thousand year old belief system, right? That's not easy. And in those situations, we had a number of meetings, and I think that the most important part of those encounters were maintaining regular and consistent communication and trying to align decision making and conversation around quality of life and values of the patient. But I could have seen them go very poorly regardless of those efforts. And we were really fortunate in those couple of circumstances to be able to kind of negotiate to something that hopefully left everyone at peace at the end of the day. But I think, you know, we don't sort of make space for those very fixed beliefs. And it's very hard, you know, to show people otherwise because they can see the tracing on the monitor and feel the pulse and the warmth of someone's skin. And I think that is very, you know, it is very hard to reconcile death, death, you know, brain death. And I don't know that I have a good frame, you know, I have my own framework for that is really just about trust and communication, and that's like a really that you have to work on very diligently to help align with families. But beyond that, I don't have a really foolproof solution for that at all.
Yeah.
So
Yeah, I have
even
sort of,
around miracles, I think that you brought up many, right, all these different approaches, but it is incredibly challenging when someone is waiting for a miracle. And my fallback now, as I shared with you before we met today, I used to kind of shy away from it, and not want to kind of engage it head on. And I over time I have gotten to a point where I sort of do the opposite. And I don't know if this is the right thing to do, despite my reading and, you know, trying to better understand it. My approach now is to just say, you know, we all, as you shared, right, we all can hope for a miracle together. That's reasonable, and we would always, you know, I would certainly want the best for you and your loved ones,
Mhm.
but we have to also think about what we're doing today, and we work with what we've got, and this is the best we have right now. And if a miracle happens, we don't stand in the way of miracles because we can't, so that's okay. And,
Mhm.
you know, we can all be hopeful together, and so trying to align around that hope while also planning for the rainy day and the bad outcome that we expect to occur.
Mhm. Yeah, and I think that's what that paper really, I think you just summed it up nicely. I mean, that's really what that paper emphasizes.
Mm. Anybody from the audience have thoughts or comments? I don't want to hijack our conversation here too much. Give everybody an opportunity.
Nope.
And Caitlin, just to make sure that I'm not misreading this, do we have anything coming in the back that I'm missing?
Nope, nothing on the back.
Oh, okay, wonderful. Just want to be sure. I also, let's see, I had a couple other questions that I wanted to what do you think about, and have you encountered much of this, where families or patients defer to religious leaders in their community, and how do you navigate those kinds of situations?
I have been pretty fortunate when that occurs, that the leaders that they'll come to the bedside even, and they're absolutely lovely, and they're usually a bit more objective, of course, because it's not truly their loved one. But they've always been very understanding, and they've been a great bridge between the family and the physicians. And again, that's just been my experience. I do think that boundaries need to sometimes be set, right? Because we can't have rounds taken over by a chaplain, which again, that's never happened. I've never had that experience. But I think that gets into that funny medical legal line too of who's the decision maker, and do you change if they defer to the pastor? I mean, does that become sort of a binding thing? And that conversation I think needs to be had. And that's what I sort of mean by boundaries. I think, happy to talk to anyone from the religious community, and I have, and sometimes they've been actually my ally in moving things forward. But I do think that that's a conversation that needs to be had is, okay, so in the middle of the night, am I calling the pastor to help make decisions? In my experience, the like I said, the pastors have really been, or whatever, the rabbi has been a bridge very much um, between the two. I haven't had them um, be unreasonable in any way, and I've found them to really offer comfort to the family. It's always been more of a where the family sort of gives up. Like it's their way of asking for help. We can't make these decisions. We need more guidance, and then that's when that religious leader comes in. I don't know. What are your thoughts on sort of boundaries and
Yeah.
who's now making decisions?
I like to keep the final decision making with the family or surrogate decision maker, who is not typically um, the religious representative or leader. I've had some family meetings where they actually attend the family meeting,
Mhm,
but
mhm.
I've tried to meet with them beforehand. I made that mistake once and I won't make it again. So I make sure that I have an opportunity to meet them and better understand their perspective before we
Mm,
all, right? It's sort of an important foundational rule of any family meeting is to kind of know all the players a little bit
yeah,
before you walk in the room.
yeah.
Um, but I try to have them serve as a consultant
Mm,
more than the final say, because I don't think that calling them in the middle of the night for the
right.
play-by-play decisions works very well.
Yeah.
I try to avoid that. We do have a question here. Um, Madhuri Nagaraj from CU and Schultz in Denver. How do you manage family discussions when there is conflict in the goals between medical providers? Recently, despite discussing together a group before going into the meeting, I was involved in a conversation for a patient where one team was pushing for withdrawal of care and DNR, and that clearly isolated the family, and it was difficult to manage, not seeming incongruous as a care team while also regaining trust and support of the family.
That is tough. That is really difficult. Mostly the recovery, right? I mean, often care teams may not fully agree one way or the other, but for one to say definitively what they want and alienate, if I'm reading this correctly or hearing this correctly, it sounds like there's two care teams. One care team approached the family and said X, and it really alienated the other care team. Is that how you're reading it, Sarah?
Yeah,
Or yeah.
yes.
Hmm.
Yeah, it's very unpleasant when that happens. I've actually ended meetings as a result of that with a statement, I'm apologizing to the family that there was that I felt like we were creating a more confusing environment, and asked them if we could reconvene after us all having more of a conversation, but also gave them an opportunity to ask questions before we stepped away. And I actually said, let me gather all of your questions so that we can discuss them as as a extended medical team and come back to meet, instead of letting the meeting kind of continue to devolve. That's maybe my recommendation, though it's sometimes not easy to step out of that, especially if people are starting to escalate, which unfortunately I have had happen. It doesn't happen often, so.
I think in these scenarios, I've tried to sort of soften the view on each side to see if they can get a little bit closer together, and then use that redirection of, well, what would the patient want? So it can sometimes minimize the conflict because you're really taking it back to what the patient would want. As an attempt, if you will, to gain that trust back, because that can be really difficult, really difficult. I hope that helps.